are the 5 possible questions again for each dysrhythmia?
What's the cause? What does it look like?
What does it look like?
Cause, nurse
Yeah.
management.
Signs and symptoms. What
And
to do,
education,
and
education.
patient education.
Nursing intervention.
Can you reiterate them?
What?
So what does it look like? What causes it? Signs and symptoms. Interventions. Interventions include pharmacologic and non-pharmacologic, and your role for each. So if the doctor performs something, what is your role? If the doctor orders a specific medication, what are your responsibilities when giving these drugs? And last would be, what will you teach the patient? Teaching usually involves either the drug or the causes, because you must teach the patient how to avoid the dysrhythmias if possible. Okay, so for AFib, there are details here on the consequences, meaning complications. So what are life-threatening complications of atrial fibrillation? All right. Okay. So it's the leading dysrhythmia. As far as dysrhythmias go, this is the leading cause of stroke in these patients. So sometimes we don't even know, the patient doesn't know they have AFib. We only know once they're already having a stroke. So patients came in with a stroke, that's when we found out, oh, you have AFib, right? And then they had no idea. Manifestations, again, for any dysrhythmia, only the severity will change. Some dysrhythmias are more serious than others, but all of them do what to the cardiac output?
Decrease.
Okay, so therefore, what are signs and symptoms? How do you answer the signs and symptoms part? Signs and symptoms of decreased cardiac output, which is the same as heart failure, because heart failure causes decreased cardiac output. Yeah. So that's the easy part of cardiac questions, because they all manifest the same. You work on a cardiac floor, no matter what the patient's problem is, all of them have decreased cardiac output. Okay. There will never be a dysrhythmia that improves cardiac output. Okay. Sinus tach may increase blood pressure momentarily as in a few minutes, but then after that, it will start dropping. Because what happens to the PR interval duration, the higher your heart rate, the narrower the PR interval. So therefore, the ventricular filling time drops. So less ventricular filling means less cardiac output. So forward blood flow suffers, okay, with each subsequent rise in, or the longer your heart rate, the faster your heart rate becomes, and the longer that is sustained. Again, clotting is the most serious complication of AFib, in addition to loss of cardiac output. We already discussed the 3 sets. So what are the 3 groups of medications you expect to give for? Okay, so we've got antithrombics or anticoagulants. Okay, so some doctors may opt for antithrombics only. Antithrombics are only 2. We have aspirin and or Plavix or clopidogrel. So aspirin, clopidogrel. Anticoagulants, we have different types, right? We have your direct thrombin inhibitors, heparin, and we've got 10A inhibitors, which are the NOACs, novel oral anticoagulants. Then you have your vitamin K inhibitor, which is warfarin. Okay, so different types of anticoagulants. Entresto is an ARB and an ACE.
Okay.
Yeah. So that's for heart failure. All right. So we'll discuss cardioversion. Again, it's in a different section of the chapter. So we'll look at your role in electrical cardioversion. And these are the chemical cardioversion agents. So doctor will also prescribe these in order to convert the patient's rhythm to sinus, from AFib to sinus using medications. If these don't work, then it will be electrical cardioversion. Okay, so let's discuss ablation therapy. As described here, ablation is done in the cath lab. Before they can do this, though, we have to put the patient under EPS. So we have to do an EPS. What is EPS? It's electrophysiologic study. So it's basically putting a dozen electrodes or more onto the patient's chest, the aim of which is to locate where the errant impulses are coming from. The doctor is trying to locate what parts of the heart are throwing the dysrhythmias. Okay, because if we say, let's say, for instance, if we do ablation therapy for AFib, so AFib, are those impulses coming from the SA node, those F waves? No, obviously not, because they're not P waves. They're not coming from the SA node. Something else is throwing those electrical impulses. Okay, so why is that happening? Remember that in utero, so let's say when Miss Hollingshead was conceived, she was one single cell. So from that one pluripotent cell became a human being, correct? So therefore, at one point, the heart or her heart was only one stem cell, and then it became a very complicated organ as a result. So therefore, at one moment in her embryonic development, the cardiac cells possessed all four characteristics before they differentiated into their specific functions, meaning at one moment, the ventricular cells, atrial cells, had the characteristic of automaticity, meaning they possess the ability to fire electrical impulses. Okay, so therefore, when we get old, again, what's the number one highest risk factor for AFib?
Decreasing
Age. Okay, so as we get older, so some of these cells become errant. You know, they start doing things they're not supposed to do, and that's one cause of AFib. So to locate that, we need an EPS first, find where they're coming from, and then once we target them, the doctor identifies, oh, these are the parts that are showing electrical impulses. Let's go burn them. So ablation is using a electrode tip catheter in the cath lab. They'll go into your heart and then burn them literally. Now, of course, could something go wrong with that procedure?
Yes.
Yes, we could eventually, or inadvertently rather, damage the SA node. In which case, now the patient has what they call sick sinus syndrome. You damage the SA node, so now will the SA node still fire once it's damaged? No. If that happens during this procedure, then the patient may require a pacemaker. They'll need a pacemaker now. But technically speaking, an AFib patient does not need a pacemaker, do they?
No.
No, only if after this, they sustain damage to the SA node, then they require a pacemaker. So here's the EPS required before the ablation can be done, because otherwise we can't just go burning areas in the atria, right? So we have to locate them first using an EPS and then destroy them. And here are the risk factors in addition to damaging the SA node. So there are risks associated with catheter ablations. That's why we don't do this routinely. Okay, there are risks involved. So we already know about tamponade, phrenic nerve injury, meaning the patient will have breathing problems because the phrenic nerve innervates your diaphragm. And of course, blood clots can form during the procedure, causing a stroke or large hematomas, bleeding, etc. So here is your nursing care after the procedure. Does not make a difference whether they had cardiac catheterization for heart attack. It is a cardiac catheterization procedure. So your care, of course, will be the vascular access. Which artery did they use in order to thread the catheter? Long gone are the days wherein we use the femoral. Most access is now the radial artery. So very short downtime. There's no activity restriction. The patient can get up, walk around after the procedure as tolerated. There's really no activity restriction. Unless, of course, it's the femoral artery, then they have to be on bed rest for 4 hours maximum, 2, maybe 4 hours. Unless they develop bleeding, then the patient may be advised longer bed rest time. All right, so it's really the artery, okay, that you watch for after the procedure. We're not doing the maze or mini maze. These are not very common procedures. A increasingly popular procedure these are for patients who are not good candidates for anticoagulation. Let's say patient's 80 years old, has dementia. Are they good candidates for blood thinners?
No.
I mean, these patients are gonna fall. You know what's gonna happen. They'll bleed. So high risk for bleeding, or especially if they've had intracranial bleeding episodes in the past, so anticoagulation is not a good idea. So this is a alternative. What is the left atrial appendage? Now, this is a part of your, obviously, the left atrium. This is a spot wherein most blood clots form. So what is an appendage? An extra thing, right? So let's say you've seen morbidly obese patients, they have extra appendages now. Oh, there'll be a small piece of fat like this big that forms. So that's one of the appendages, or appendages are your arms. So this is the left atrial appendage. So this part here, it will act like a you've seen a stream, right? Or a river. Along the river edge, are there sections wherein water gets stuck and can't roll? Okay, so think of it that way. So blood can pool here and get stuck, and what will happen, of course, what will form if blood gets stuck there? A clot. So in order to prevent that, because again, most blood clots for patients with AFib form it right here in this appendage. So what they'll do is get rid of that appendage. So they will put a device here. It's a mesh which they'll install in here. So therefore, will blood still pool in there? No, because you occluded it. So this is the point of this procedure. So you'll put a mesh into that left atrial appendage, and therefore no more blood getting stuck. So therefore, no blood clots. Do they still need anticoagulation?
Yeah.
Not likely. Okay, not likely. Again, who gets this?
Oh, people who are
Okay, bad candidates for anticoagulation. So this is the most popular brand, Watchman. But there are, of course, alternatives, cheaper alternatives. So this is what it looks like. The Watchman. WPWS we're not doing. Okay, let's go to Aflutter. So this is the sister of atrial fibrillation. We won't discuss this very long. It's really the same consequences as AFib. Causes similar as well, treatment similar. The only difference is the appearance. Of course, this does not look like AFib. This is compared to AFib, which is very irregular. This one is actually very regular. So the atrial rhythm here is regular. Only the ventricles can be irregular, but most A-flutter patients have both regular atrial and regular ventricular rhythm. Because this is atrial flutter, do you see P waves? There are no P waves here. Here, no P wave. What you'll see instead are sawtooth shape. We call them again F waves, so or flutter waves. This is a flutter. So different definitely from compared to AFib. Let's look at AFib again. So here's AFib. Different, right? Okay, so this one is irregular, whereas the A-flutter is more regular looking compared to AFib. But just the same, these are not P waves. So therefore, what is the consequence? What will form? Blood clots. Okay, so same. Again, treatment will be the same. Manifestations will be the same. We'll skip junctional dysrhythmias. There's a not very common dysrhythmias. Let's go now to ventricular dysrhythmias. First one and most common is our PVCs. Causes, do you identify? Okay, same as PACs. So every now and then, if you drink coffee or sports drinks, for instance, especially those monster drinks, you know, yeah, the 5-hour energy, Red Bull. Okay, so those contain sympathomimetic agents and can cause PVCs. Are they serious? Well, it depends. If you have an otherwise healthy heart, no cardiac history, you'll be fine. Okay, no wonder you're still alive today. The only thing you'll feel are palpitations, maybe your heart skipping a beat. Okay, because it technically does. Okay, because there's a pause. I don't know if you remember last week under PACs. There was also a pause after the premature contraction. So let's say here that there are many variations for PVCs. There are different patterns. So for instance, this one is a PVC because the rhythm is supposed to be this one. These are the patient's underlying heart rhythm. This is the patient's regular underlying rhythm. However, every now and then they'll have a distorted QRS. So did this QRS look like the other QRSs? No, this looks very different. So that's what we call a premature ventricular contraction. Another thing is, remember the Foreman's caliper we did last week? Okay, so let's use one again. You mark here, this is the original interval for your QRS complex. Okay, so clearly, did this one occur at the right moment? No, this one is premature. Right, earlier, occurred earlier. Causes again, what's causing it? Okay, caffeine. This is also common after a heart attack. Let's say you have a MI. Doesn't matter where it's STEMI, non-STEMI MI. You will have PVCs. So this is caused by irritability of the ventricles, meaning something's causing the ventricles to be overactive. Again, most common substances besides particular drugs are like cocaine, for instance, are, so your meth, okay, is that what you want? Or the coffee again, the nicotine. Okay. Bigeminy is if they occur every other beat. Bigeminy, I don't know if we have pictures. No. All right, so let's show you, but again, it's only the rhythm strips that are on your textbook, but just so you can be familiar with what Bigemini look like. So here you have every other beat is a PVC. Every other. So sinus PVC, sinus PVC, sinus PVC, right? Every other Bigemini. If it's also called trigemini if it's every third beat. Okay, so sinus, sinus, PVC, sinus, sinus, PVC, then that's trigemini. What do you think will it look like if it's quadrigemini? Every fourth beat. Sinus, 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 PVC, sinus, 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 PVC. Okay. It can also be in succession. So let's say if you have two PVCs in a row, we call it a couplet, a couple, no, couplet. Three PVCs in a row, triplet. Four PVCs in a row. Okay. Five or more, we don't call them quintuplets anymore. We now call them VTAC. Okay, it's now called VTAC. It's five or more, but four, two in a row, couplet, three in a row, triplet, four in a row, quadruplet, five in a row. No. Ventricular tachycardia already. VTAC, that's dangerous already. All right. We'll talk about VTAC a little bit later. So here, patient, you may feel nothing or you skipped a beat. Because if you think about it, did it really skip a beat? Yes, there's a pause here. It's not very long. It's not like a minute. Okay. It didn't pause for a minute, but there was a moment wherein the heart did not beat. So think of it as, let's say, when this occurred, the heart started, tried to restart. Like the heart kind of thought like, WTF, this happened. Okay, and then the heart had no idea. Okay, let's resume. Okay. So every time it happens, it's always followed by a short pause. Okay, a very short pause. But enough for the patient to feel it. Okay, that like their heart skipped a beat. Same thing also, if you remember again with PACs. After a PAC, there was also a pause. Okay. What do we do? Well, again, depends on what the patient is feeling. If the patient is symptomatic and your blood pressure, especially your blood pressure is affected, do we have to treat it?
No.
The blood pressure is dropping.
Yeah.
The patient's symptomatic. Do they need treatment? You have to treat it. Usually it's beta blockers. But again, if the patient is otherwise okay, no symptoms, blood pressure's all right, it's normal or even, a little bit high, we don't do much. We just try to identify and eliminate the cause. Okay, maybe the patient is drinking coffee. All right. But if they're frequent and persistent, then we treat them with what? Amiodarone, beta blockers. So you're required to report it. So you if they're occurring very frequent, so just send your doctor a message if you don't want to call, because it's not always, again, life-threatening all the time. So you can, non-urgent calls, you can just send them a message and then they'll get back to you. But definitely if it's causing symptoms, or if the patient has now 5 or more, that's VTAC, right? So you have to call the doctor right away. Here's the 5 or more. So VTAC. Well, depends on the appearance, okay? Because sometimes it's not VTAC. If let's say you have 3 in a row, but they are clearly PVCs, because VTAC is different. Look at that's VTAC. Okay, so was it VTAC looking when we looked at the triplet, or no? That's clearly a PVC. This one Is this still a PVC?
No.
These are not, do you see P waves? No. Are they QRSs?
No.
No. So if it's VTAC, then, okay, there are two types of VTAC though.
Also,
There's monomorphic. This is monomorphic. Polymorphic VTAC is, remember when I showed you the picture of Torsade de Pointe?
Yeah.
Okay, so that was, if you don't remember, so this is polymorphic PVC. So if it looks like this, the points are twisting. Okay, so it's twisting. Looks like this, then that is Torsade de Pointe. Okay, but it's still a life-threatening rhythm. Okay, it doesn't mean oh, that's okay, that's polymorphic. No, that is just as serious as VTAC.
Is there like a-
Polymorphic.
Monomorphic. So this is monomorphic. Figure 2216, this is monomorphic VTAC. And this is polymorphic.
For the PVC strip, is there anything like specific that would signal you to know that that's a PVC?
This is all you have, so this is all I'm using.
So just remember exactly what it-
Right, so if you see, let's say, if the PVCs all look the same, so let's say this one, and this one, are they the same?
Oh, so the PVC is when it dips?
No, it's a distorted looking QRS. So this is a QRS, right? That's the normal QRS.
Yeah.
So this one, does it look
Okay.
like the same QRS? No, clearly, no. Plus it occurred prematurely, right? Every PVC is always distorted, just like the PAC also did not look like the same or a regular P wave. So this one, is this a regular looking QRS?
That one, yeah.
No,
Wait.
no, this one.
Oh, no, because it has the dip.
No.
Right, so this is a PVC. So that's a PVC. If they look the same, we call them
One polymorphic.
no.
Five.
So have they?
Okay, unifocal. Okay, if it's the same, it's called unifocal, meaning it's likely caused by the same source. Meaning
So wait,
there's
what's that
one
last
part of the ventricle that's throwing these irregular impulses.
What about that last part? where it's
Okay.
Upside down.
So this one now, if you have a different looking PVC, these are not we call
Multi.
multifocal,
Okay.
meaning there's more than one source causing the PVC.
Also, the first one is the.
Yeah, they look the same, like here, this one, most likely caused by the same errant
I mean, the strip
cell
above
in
it.
the ventricle.
The strip above, the small one above.
It's not very clear. Well, this one would be monomorphic also, because it's the same. See,
It's a
this one and this
unifocal-
one,
unifocal?
sorry, unifocal,
Okay.
because it's the same cause, the same source causing the PVC. Okay, throwing that irregular premature beat. This one, since they're the same, this one, if there's none of this, it looks like this one, it's called unifocal. So unifocal, and then this one will be, because there's two in a row, you'll call this a
Unifocal.
unifocal couplet, right? Yeah, because it's a couple. Okay. This one, because you have a sinus here, sinus beat, and then another PVC, but since it looks different from the other PVCs, so this is now what we call multifocal PVC with multifocal PVCs. So if you were to interpret the rhythm, this would be sinus rhythm with multifocal PVCs. What?
Polymorphic.
No, polymorphic is this. This is polymorphic.
But it's more than one.
Oh, different.
More than one lead or more than one, like.
No, because this is monomorphic, right? This one,
Oh, that one, yeah.
monomorphic, same, right? VTAC. This is VTAC though. This is not PVC.
Oh.
All right, don't confuse them. All right, so this is VTAC. This is polymorphic VTAC, monomorphic VTAC. Yeah, this is Torsade de
First
Pointe.
side is the point.
Don't confuse this with PVCs. These are not PVCs. Okay, this is VTAC, ventricular tachycardia. Johnny, you had a question? Not this one. So only what's on here.
No, determining of
That's okay. There's really no discussion about it. So I'm just telling you that this is unifocal. If it's look the same, that's unifocal, right?
But you said that there was two of the same ones happening, each time it's, unifocal.
Yeah, this is couplet.
Yeah.
There's three of them, triplet. Yeah,
Then more than five is VTAC.
most likely.
Yeah.
Okay. So we did management. Okay, so VTAC, again, this is what it looks like. Now, there are two types here. There are two possible types of two events that could happen. A VTAC can produce a pulse or there's no pulse. Now, you have to make the distinction because the treatment is night and day. If the patient has no pulse, we call a code
Mhm.
because this is a non-perfusing rhythm. So we have to defibrillate. If there's a pulse, we don't defibrillate. We treat it with amiodarone. Clear?
Yeah.
All right. So therefore, if you see this, what's the first thing you do?
See if there's a pulse.
Assess for a pulse. Again, if you see VTAC, what's your first action?
Assess
The
for pulse.
pulse.
Check for a pulse.
So no pulse equals shock.
Right. So if no
Okay.
pulse, get a defibrillator. But are you carrying a defibrillator with you
No.
all the time? Do you have it in your fanny
No.
pack? No.
CPR.
CPR first. Okay. All right. Are we together on this? Okay, so let's go back again. So PVC, VTAC, this is a problem, right? Okay, so what's your first action?
Assess the patient for.
Okay, so check for a pulse first. So if the patient is unresponsive and pulseless, what's your next action?
CPR.
No, call a code first. Okay, so, right. So after you activate, pull the cord or just yell. Code, whatever code you have, code blue, or some hospitals have a number, let's say 101, 101C, whatever your code is. So call for help first because you can't be alone there. Because
Yes.
if
Somebody
you
gotta
start
support.
chest compressions, who's gonna relieve you? Can you do this by yourself?
No.
Call for help first. Somebody will the team will come over. You begin chest compressions. Okay. They come in and then because we have to put the pads and then they'll defibrillate. Yes. Say again.
Oh, the locus.
Yes, they do. If your hospital has that, then good. That way, it's consistent. It's perfect. Rather than humans, let's say my compressions won't be the same as yours because you're stronger, and I can't last more than 30 seconds. I'll be, I'm not ashamed to admit I have to ask for a switch after 30 seconds. Hey, switch. Okay.
So if it's less than 100 BPM, is it still VTAC?
Well, it's not really the rate, but the
The rhythm.
rhythm. Okay. So regardless of what that rate is, this is a non-perfusing rhythm. Are we clear? What's the first action again?
Assess.
Call the code.
No. Check for pulse first. Okay, and then pulseless, follow code. Okay.
CPR.
So if the patient has a pulse, these are the possible interventions. So procainamide, amiodarone, Sodalo, lidocaine.
Why lidocaine?
Or I need the blue hand.
Lidocaine will interrupt because if you give lidocaine, why can't you feel the part that you put lidocaine on? Because what did you you interrupted the electrical impulses, so same effect. So instead of giving this IM though, this is given IV.
What in cardioversion?
Okay.
So
So-
if you don't have a pulse after the CPR, what drug? Oh, it's like epi.
Epi and atropine?
Well, what's the question again? If
Like if
the
they don't have a pulse, you said these drugs are given if they do have.
yeah, no pulse, then we do ACLS.
Okay.
Okay, so ACLS is not discussed in this chapter nor in this textbook. ACLS is a separate discussion. That's from American Heart Association. You can do that after graduation. If you, let's say, have downtime, don't have a job yet, you can get your ACLS certification. It's very easy. Go online. You have a 2-hour training online. You memorize the algorithm, and then you go for testing. Testing will probably take
15 minutes.
or less, depending on the mood of your if your session is early in the morning, your testing will probably be longer because the instructor is fresh. But if it's late in the afternoon,
Yeah.
evening, they're tired. So they'll just see if you can answer the questions, and then that's it. See you in 2 years. Yeah. Again, we won't discuss ACLS. We do have BLS because you are all certified. You have CPR. I mean, you know CPR. You have your BLS card. Okay. Cardioversion is a choice. Again, the doctor decides which one to use. Cardioversion is not the same as defibrillation. All right. However, the equipment's the same. So if this is your
It's the voltage.
But
okay, let's look at the depending on the scenario. So this is your
It depends on what voltage.
defibrillator. We have one downstairs too in the lab. So this is the same. If you're using the machine for defibrillation or for cardioversion, it's the same machine. Okay. The only difference is you turn on the synchronize button. Okay. All right. So in the where's the sync button?
right there, under the shock.
Oh, right here. So if your doctor is performing a cardioversion, the only thing that will convert this to a cardioverter is this button right here. So if you turn this on, you'll of course turn green. There you'll have a bright green light here. Then it becomes a cardioverter. Okay, so you can use it for cardioversion. So what's the difference between defibrillation and cardioversion?
Not time,
Okay.
The heart.
and the cardioversion is.
To regulate the-
Right. So in cardioversion, it's usually used for a patient who has a heartbeat. Okay, they have a rhythm. In defibrillation, it's only used for 2 rhythms, which are VTAC, pulseless VTAC, and
And VFib.
ventricular fibrillation. Those are the only 2 shockable rhythms. Are we clear? So AFib, A-flutter, VTAC with a pulse, those can be cardioverted. All right, meaning the patient has a heartbeat, they have a cardiac output. That's who are cardioverted. Defibrillation is used for what 2 rhythms again? Pulseless VTAC and VFib only. That's it. What about asystole?
You don't shock.
You can't shock.
Please do not shock asystole. Okay, because if you do,
That's it.
you're just barbecuing the patient.
Yeah.
Mhm.
Okay, it's the same as electrocuting the patient.
Yeah.
Mhm.
All right, because if in asystole there is no rhythm, there is no electrical impulse. There's nothing to convert. Are we clear? So nothing to defibrillate. Do you understand? Okay, so the only thing you do for asystole is what? Chest compressions. Okay, get that blood moving. Yes, again, we don't discuss ACLS drugs. Okay, but later when you get your own ACLS certification, you learn about ACLS drugs. All right. Again, that's outside the scope of this chapter or of this textbook. Yes, sir.
They're dead anyway. Right?
Sorry.
They're dead anyway.
Well, they're not dead yet.
Exactly. They're not dead yet.
Yeah, so we can still
Depends
revive
on
them.
How long the compressions are.
So again, for asystole, all you do is
Chest compression.
good quality chest compressions. Get that blood moving because As long as you have blood pressure, you're generating blood pressure, you're pushing the electrolytes in and out. So therefore, when your potassium, calcium, sodium is being pushed in and out of the cardiac cells, what are you generating?
Creating an
Electricity, okay? You can't generate electricity, or you cannot generate power without electricity. So you have to circulate blood. The only way to do that is good quality chest compressions. So patient has asystole, or they have a pulseless VTAC or ventricular fibrillation. What's the first action? Chest compressions, okay? Good quality chest compressions until someone puts the pads on, and then we can defibrillate. Of course, defibrillation is the ideal, but again, do you carry a defibrillator with you?
No,
Is it in your fanny pack?
no.
Who wears fanny packs here? Okay, all right. So you have to generate the circulation first, okay? Generate blood pressure by good chest compressions. Torsade point is mentioned here, but there's really no picture, so we won't do that. So here's the other shockable rhythm, BFib. So yes, there's disorganized electrical activity, and that's what it looks like. I mean, very disorganized, no P waves, no QRSs, no ST segments, no T waves. Highly disorganized, so there's really no cardiac output here, okay? So this is shockable. Again, if you don't have a defibrillator with you, begin with chest compression. So always call for help though. Hey, so it's up to you if you want to do it hysterically or just coolly, like say, just yell out to somebody, code blue. Okay, same thing. Okay, as long as you activate the code. Never joke around, okay, about these things, because you know you'll be a boy who cried wolf. Okay, people might not believe you, and that becomes a reputation, like you're joking around. Don't joke around with codes. All right, that's something you don't joke about, because again, you'll be a boy who cried wolf. Nobody will believe you, unless of course you go hysterical. I usually just go code blue, and then people would, you know, because they know I don't joke around. You know BLS, right?
Yeah.
So BLS. So again, hey, you call. Call the code. So I'll say to Trinae, code blue. Okay, so you go grab the crash cart, and then somebody will announce it, okay, overhead, that you have a code, and then people will come over. So high quality CPR until you get the defibrillator. And then again, we won't test you on the ACLS medications. Okay. Yes, sir.
I read somewhere that the third shock doesn't work when you're doing the defibrillating for the BFib.
Uh-huh.
You give magnesium sulfate.
Yes, again, that's part of ACLS drugs.
So just do the AFib. We don't need to do idioventricular.
Okay, let's do the last three, which are the heart blocks. Okay, so there are 3 types of heart blocks. First degree, second degree. No, actually 4, sorry. Because there are 2 types of second degree, and then we have third degree heart blocks. Okay, let's get started with first degree. This is pretty quick. The only thing wrong with a first degree AV block is the heart rate. Okay, the heart rate is low because the PR interval is longer than 0.2 seconds. Clear? Okay, so that's why the heart rate drops, because the PR interval is way too long. It's more than 0.2 seconds. What should it be? 0.12 to 0.2 seconds. So it's only supposed to be between 3 and 5 small boxes. Okay. And this is what it looks like. So it may reach 60 in some. Okay, still be 60, maybe 61. But definitely the PR interval is longer than 0.2
0.2
seconds. Okay. So because that's the only thing wrong, so do we need to do anything?
No.
Okay, depends. If the patient is symptomatic. So if they're symptomatic, then we treat them. What's the drug of choice? What did we treat sinus bradycardia?
Oh,
Atropine. So this patient will receive atropine. Okay, if what?
Symptomatic.
If symptomatic. Meaning sinus bradycardia, first degree AV block, do they receive atropine right away?
No.
Always assess the patient. If symptomatic, then they will receive treatment. Are we clear? All right. Second degree heart block. Type 1. In type 1, also called Mobitz 1, the PR interval is still long, but it gets longer and longer. Okay, so first prolonged AV PR interval, and then the next one will be even longer, and then the third one will even be longer. So it gets longer, longer, longer. So that's now called second degree type 1. Is it treatable? Depends again if the patient is symptomatic, but typically second degree type 1, they're okay. Okay, you will see second degree type 1, they're asymptomatic. Okay, your vital signs are still good, your blood pressure is good, so just watch them. Type 2, however, is now dangerous because the patient now loses a. Okay, so here's type 2. The patient now loses a ventricular contraction. Now they lose a QRS. In type 2, there is no progressive lengthening of the PR interval. In type 1, what happened?
Progressive lengthening.
Progressive lengthening. Long, longer, even longer. But they don't lose any QRS. There is a QRS for every P wave.
Wouldn't that mean that the second degree will need like a pacemaker?
Yes. Okay, so we'll get to the, again, pacemaker is separate, but we'll mention that here under management. So what is second degree type 2? The PR interval remains the same. No gradual lengthening. However, they now lose a QRS.
Wait, so the PR interval is lengthened, but it's the same throughout?
In which one?
Type 2.
You mean type 1?
Type 1 is it?
Type 2? Yeah, the PR interval does not get longer. Stays the same. However, they lose a
It's
QRS.
still longer than it should be?
Yes.
Okay, that's okay.
So here you have a QRST, P, it's missing one, right? There's no QRS here. And then now you got a PQRST. You have another P wave, prolonged QR interval, but then missing another QRS. Okay, so therefore, what happens to your overall heart rate here? It will drop. The ventricular rate will drop. Okay, in second degree type 2. So this one definitely needs treatment. So either atropine or a pacemaker. Third degree heart block is now the worst because there are more than the patient has a separate atrial rate and there's also a separate ventricular rate. Meaning this is also called two other terms. So besides third degree heart block, it's also called a complete heart block. It's also called AB dissociation. Okay, so a very familiar way to remember this as taught by my instructor, he said that compare this to a relationship. Okay, so let's say me and Michaela. You mind if we go out? Okay, so me and Michaela are going out. So let's say every time we go have dinner, in first degree AV block, I show up late. Okay, but I consistently show up late. Okay, so the same. I'm always 1 hour late. Okay, so she finishes through her meal. The candle is now almost, burning out, okay, by the time I get there. But I show up. Okay, I show up. So are you likely to stay in a relationship? No, I mean, I show up though. It's not like I'm not seeing anybody else. Okay, I'm seeing just you exclusively. Okay, just things just happen. I just can't get, something always happens. Are you okay with that? So can we still stay together? Okay, yeah. So she's understanding. So that's first degree heart block. Okay. In second degree heart block, I get later and later. So one time I'm 15 minutes late. The next time I'm 30 minutes late. The next time I'm an hour late. Okay, but I showed up though. Okay, I showed up. I just get inconsistency. Okay, I'm inconsistent. So can we still? Okay, I mean, I show up though. You're still together?
Mm-mm. So an hour late after you told me no.
Just tell you maybe my.
But I'm faithful. Okay, no, I don't see anybody else. Okay, I'm devoted to you. I gave you, we're engaged.
Mm-mm.
Okay, but I just show up late. Okay, late, later, and even later. Okay, but I show up every time. In second degree type 2, am I still showing up?
No.
Sometimes I stand her up now. Okay, so here, sometimes I'm not showing up. I'm absent now. I totally ditch her. Right? So therefore, is she bound to?
I got another one.
Okay, so she'll now start not answering my calls now, right? So is the relationship very rocky now? Okay, so it's all my fault though, okay, because I'm not showing up. Okay, I stand her up. How about here in third degree heart block? Are we even together? No.
She forgot about you.
Right. So she has her own life. Look at this. She has her life. I have mine. So if you look at it, look at the atrial and the ventricular rate. So these are the P waves. That's a P wave. That's a P wave. Look at the rhythm of the P wave. Is it regular?
Yeah.
It's regular. All the P waves are occurring at the same time. All right? You understand? Look at the QRSs. See?
Yeah.
So are we still together?
No.
We are living separate lives. So if you look at it in the heart, is the P wave, is the SA node firing?
Yes.
Yes.
Yes, you see P waves. It's firing. Is it reaching
No.
No.
the AV node?
No.
No.
Obviously not. Okay, so for some reason, we don't know what's causing the block. That's why I call the heart block, complete heart block. The SA node is firing. They're just not getting to the AV node. And what is the role of the AV node?
The backup.
The backup.
It's a backup. It's a secondary pacemaker. It is a pacemaker. However, so it's saying, so as far as the SA node is concerned, SA node's firing, and then the AV node is saying, well, I'm not getting any. What's your problem? SA node saying, well, I don't know about you, but I'm firing. AV node, well, you're not firing. I don't get any, so I'm going to fire my own. All right? So therefore, if you count the heart rate though, the atrial rate is how many? So this is a 6-second strip. 1, 2, 3, 4, 5, 6, 7, 8, 9,
90.
10, right? So let's say this is not really a true 6-second strip, but let's just say 6-second strip. So it's around 90s, right? Look at the ventricular rate. 1, 2, 3, 4, 5.
Slower.
Why?
Because the atrial
AV node is only capable of 40 to 60. Clear?
Yeah.
Any questions on heart blocks?
For now, no.
Bruno? Smith? Smith, right? Which Henry are you? Chio, huh? Tahina. Okay.
When you kept saying that, weren't showing up, what is that?
Here or no, me not showing up is a second degree type 2.
Yeah, but
Here.
what does that represent?
What do you mean? No, here. So because they're supposed to be, this one's complete, right? P, Q, R, S, T. P, Q, R, S, T. P, no QRS. P, Q, R, S, T. P, Q, R, S, T. P, no
Okay,
QRS.
so you're saying sometimes there's no QRS.
Right. It's being dropped. Yeah, this is type 2. Second degree type 2. No, this is type 2.
It says type 1.
Sorry, that's here's type 2.
Okay. Go over which, do the same thing again, like which one?
I know separate is in type 3. Third degree, sorry. In third degree, we are no longer together.
Because there's no QRS.
No, there are different times, right?
Yeah.
So we have a separate, a higher atrial rate and then a lower ventricular rate. Because the AV node only fires between 40 and 60.
So would treatment also be a pacemaker?
Pacemaker.
Okay,
Pacemaker.
no medication, just.
So remember, you can't survive
Temporarily, but
40 to
it's
Arrow.
So you said there's a higher ventricular rate than atrial?
there's a yeah, so this one is a P wave,
The first one, P-wave.
right? So this is another P wave.
Third one,
So where's the QRS? Is it?
Here, these are your
Is it
QRSs.
low or something?
Yeah.
You barely see it. It goes
Here,
up to the
QRS.
No, you can barely see it.
So QRS,
It's like a little arrow.
here.
It's
Yeah,
like-
because they put it on blue, but on your test paper, because it's printing black, so this should be clearer.
so without.
Yeah, they're not talking to each other. Meaning, yeah, there's a separate atrial rate, which is regular.
Meaning it's not connected?
They're not talking to each other. Again, that's why we call it a heart block, is because the SA node
They're not synchronizing.
is not reaching the
The AV
AV node. Right. So it just depends on the degree. So this is third degree. This is the worst type because there's a complete heart block. So here in type 2, second degree type 2, you can say that it's still reaching because some of them are complete. See, P wave. So it reached the AV node and it fired, right? See, PQRST. P. But then sometimes some of them don't have it, meaning some of them don't reach the AV node, meaning that's why there's no QRS for this one. And then again, sometimes it does. Okay, so here it does. Okay, so this is much worse than the other one. So this one's type 2, second degree type 2. This is second degree type 1. Okay, so you have PQRST, PQRST, P, and then nothing here. PQRST, 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 none. Okay, but unlike in type 2, wherein you have more times that I don't show up, plus this one is getting longer and longer, right? Long, longer, even longer, and then drops. All right. So let's go to the treatment. So treatment is atropine initially for first degree type 1, first degree, which is symptomatic, first degree symptomatic, and then second degree type 1 can be treated with atropine. Again, if symptomatic. So here, if patient is stable, no symptoms, no treatment is indicated. We just focus on identifying and eliminating the cause or decreasing the cause, whatever that is. Could be the beta blocker, could be the digoxin. Okay, so those are the common drugs causing heart blocks. Yeah.
What the beta blocker become?
In
Any patient?
yes, there are always contraindications for every drug. Say
Which patient will the beta blocker be contraindicated?
definitely any heart block. Do they receive beta blockers?
No.
No, because that could be the one causing the dysrhythmia in the first place. Okay. So that's what I'm saying. If it's caused by a beta blocker, then you hold that. Okay. That may be the only treatment for first degree heart block. All right. If symptomatic, initial treatment is
Atropine.
atropine. Now, if the doctor orders a pacemaker, we always start with a temporary pacemaker, which is your defibrillator. So you grab your defibrillator, put on your pads, turn on the pacer function. Okay. So here's the, okay, so here, turn on the pacemaker function. So turn on the pacer and it will act like a pacer. Right, so you have your patches, one here, and then it will fire small electrical impulses. Okay, so this is an obviously external pacemaker. This is only temporary.
Are they supposed to be awake for that or no?
Oh yeah, because the electrical impulses are so small,
Okay.
no, the patient won't really be bothered by it. Right, but of course you don't want this long term. This is not effective. Okay. So that's what we call transcutaneous. Okay, transcutaneous is just over the skin. So you just have patches here, 2 patches, and then it will fire electrical impulses across your skin into the heart. Now there's a, so therefore, will there ever be a emergency permanent pacemaker insertion? Like you'll call the doctor, hey, come in. We need a permanent pacemaker at midnight. Come here at midnight. No, nobody will come because we have a temporary. Okay, so there's no need for the cardiologist to rush in, okay, or wake up. They won't even be called. Call them in the morning, okay, because we have a temporary pacemaker. Okay, so if there is a transvenous is still a temporary pacemaker. The wires are inside the patient. It's in the ventricles and the atria. However, the device is outside. Okay, we call that transvenous. Okay, so we have a transcutaneous, which is outside. Even the patches are outside. Okay, so that's transcutaneous. Transvenous, the wires are inside the patient's heart. It's in the atria and the ventricles, you know, to fire into the patient's heart inside the chambers. But the device itself, the pacemaker device, is outside. Okay, so who will get that? Usually that's a bridge. Let's say the patient has an existing infection. Okay, so let's say Tinine. Okay, so let's say Livingston has an infection. She's septic right now. And let's say she has endocarditis, but she has a 2nd degree type 2 or a 3rd degree heart block. Can I put a permanent pacemaker now? No, she has an active infection. Because if a doctor implants a permanent pacemaker in her now while she has an active infection, what will happen to that pacemaker?
It'll be a root for infection.
It will grow bacteria. Okay, so you're giving the bacteria a nice house, an expensive house to live in. Here's a mansion. Okay, here, you can live in that pacemaker. Oh, don't mind if I do. Okay, so that's what will happen. So therefore, that's the scenario wherein why would someone receive a transvenous? So that's an example. Okay, it's a bridge. We can't do the patient needs a permanent pacemaker. We can't put it in yet. Okay, not right now. Okay, we need to treat this patient for this infection. And then after the infection is clear, then we can put in a permanent one. Okay, so again, who needs a permanent pacemaker? 2nd degree type 2 or 3rd degree. Again, we're not the ones deciding this, okay? It's the doctor. So you just focus on what are your roles in these procedures. Clear?
Yeah.
Okay. So who needs a pacemaker?
Second degree heart block type 2 and third degree heart block.
Very good, children. Okay, we'll discuss the ICDs next and the pacemaker also. Okay, so let's differentiate again, cardioversion and defibrillation. So the same machine, the only difference is, what do you turn on? Okay, the sync button. Okay, so if the intention is to cardiovert the patient, again, another term here is electrical cardioversion, you turn on the synchronize button. Then the machine becomes a cardioverter. It's no longer a defibrillator. Okay, but the same machine. What turns this into a pacemaker? A temporary pacemaker, the pacer button. Turn it on, apply the pads, it becomes a temporary pacemaker. If both are off, what is it? It's a defibrillator. Okay. So let's look at the difference. Thank you for reading, McCrae.
The major difference between cardioversion and defibrillation is the timing of the delivery of electrical current. Cardioversion, the delivery of the electrical current is synchronized with the patient's electrical events. In defibrillation, delivery of the current is unanswered.
Okay, so what does that mean? Let's start with defibrillation. Okay, so if I use this as a defibrillator, the sync and the pacer button must be off. Okay, they must be off because otherwise this won't work. Right. So I have the pads on. I see what two rhythms are shockable. Okay, so I see either pulseless VTAC or VFib on the monitor. What will I do? Charge. And the machine will deliver the shock. So the shock is delivered when? As soon as you press the button. As soon as you press this shock button, it will give the shock. Okay, no delay. Press it. All right. Of course, charge and then bring up your charge. Usually, if it's defibrillation, we start at 150. 150, 200, 250, 300, whatever the doctor wants. Or depending on how many times we deliver the shock. Okay, so understand any question on defibrillation? No. Okay. Sorry? Yeah, the difference between cardioversion and defibrillation. Okay. So, it says you here, if you're using it as a cardioverter, what should you do? Okay, now you turn on the sync button. Now, when is the delivery of the electrical shock now? Is it right after you press the button? No. The machine decides when they will deliver the shock. Okay, the machine is in charge now. So when does it deliver it? No. It synchronizes it first, and then it will deliver the shock at the peak of an R wave. At the peak of an R wave. Right here. It's right here, electrical cardioversion. So here, in cardioversion, the defibrillator is set to synchronize with the ECG so that the electrical impulse discharges during ventricular depolarization, ventricular contraction, which is represented by the R wave. That's the peak of the ventricular contraction. So if you use a defibrillator as a cardioverter, you turn on the sync button, correct? And then as soon as you do that, when you press the shock button, it will take a few seconds. It will synchronize first and then deliver the shock at the peak of an R wave. Okay, so it will analyze the patient's rhythm first and then time it exactly at the peak of an hour wave.
You said that it is used for AFib or VFib?
What's the only treatment for VTAC and VFib? Pulseless VTAC, defibrillation.
Okay.
Everything else can be treated with cardioversion. Okay. So let's say VTAC with a pulse, AFib, A flutter, those can be treated. SVT can be treated with cardioversion. Right? Again, the doctor decides, okay, not us. Are we clear?
Yeah.
All right. So we don't initiate cardioversion. Are we clear? All right. And cardioversion, since although the number of joules is starting lower, unlike defibrillation, wherein we use 150, that's a lot. 150, 200, 250 or higher. And in VTAC and VFib, is the patient conscious?
No.
No.
They're alive, they're conscious, they're awake, and they're in VFib? No, because there's no cardiac output. There's zero cardiac output. Of course, the patient's unconscious, unresponsive. Clear? So that they feel the electrical impulse.
No,
No, the electrical shock, sorry. No, they're unconscious. So you get the shock. Don't worry, they're unconscious. Okay. In cardioversion, though, is the patient awake?
yes.
Yes. Do you want them to feel it?
No.
Like, are you ready?
Date.
We're gonna do cardioversion, okay? Okay. Here's a stick. Bite on this. Girl, are you ready? No. We have to sedate the patient. Okay. Or sometimes they won't completely sedate you. They'll just give you something, to take the edge off, but you will receive something. Okay. And since as long as it's scheduled, because we can do emergency cardioversion as well, they do it in the ER all the time. But if it's a scheduled cardioversion, do we get consent?
Yeah.
Yes, we get consent. We get a sedation, just moderate sedation, so the patient at least is comfortable. Because this is still electric shock. Okay. Again, we can't do that. Okay. All right. Any questions? Okay. Sarah? Okay, so for cardioversion, we usually start at 50.
Okay.
Yeah, lower, yeah, 50 and then 100.
With external defibrillation, right?
Say again?
The chart 2020.
Yes.
Okay.
All right, one more thing here, detail. If cardioversion is elective, meaning we schedule this, the patient must have been on anticoagulation for a few weeks, because cardioversion can accidentally dislodge a clot. Okay, so if the patient has been in AFib for a while, that means could they have formed a clot?
Yes.
Yes, so we put them on anticoagulation first. So we'll do it, let's say, 4 weeks from now. Okay, come back in a month, take this warfarin or whatever the doctor prescribes, take this, and then we'll schedule it 4 weeks from now. So when they come back, we'll do an echo, look for a clot, just to make sure, okay? Are there really no clots there? Once confirmed, no clots, okay, let's do the cardioversion. If it's elective, all right? Are we clear?
If it's an emergency.
Of course, when we do emergency, then we assume that the AFib or A flutter or whatever the cause was like right now, sudden. So there's not likely to be a clot yet.
Okay, so it's not possible that.
Well, not likely.
Okay.
But if it's elective,
Yeah.
no, definitely, yeah, definitely there could be a risk for a clot already there. So we put them on anticoagulants first. Okay. So here's the defibrillator. So that can be as high as 360, or you can start at 150, 200. That's a lot. And in between, of course, BLS, so to do chest compressions in between shocks. You don't have to do these. Again, these are ACLS drugs, including the magnesium that Chris asked about earlier.
What?
The magnesium.
You know, you asked about magnesium
magnesium. Oh,
sulfate.
yeah, yeah.
Mhm.
Again, this part is not tested because that's ACLS. EPS, I already described what it is, so I won't go because there's really no role. That's why I'm skipping EPS because we're not involved here. This is done in the cath lab. The doctor does the study. There's really no nursing role to speak of. And we sit there, stand there, look pretty. Okay, pacemaker. Because we're in charge of teaching the patient. So what do we teach the patient? All right, so let's talk about the settings first. There are two settings here. Okay, so pacemakers can be set to on demand, meaning it will only fire if the patient's intrinsic rate falls below 70. It's usually 70. I've never seen a pacemaker set at 60, usually 70. So if the patient's heart rate falls below 70, then the pacemaker will start firing. Clear? As simple as that. It can also be fixed, meaning regardless of what the patient's SA node is doing, the pacemaker will fire. Are we clear? Okay, so again, what are the two most common settings? On demand or fixed. Fixed is also called asynchronous. On demand, there is a rate preset by the cardiologist that if the patient's intrinsic rate, the SA node, will fire less than 70, the pacemaker kicks in.
That's fixed.
On demand.
Fixed is.
Fixed is regardless of what the patient's SA node is doing,
Okay.
the pacemaker is firing. All right. So what will you see on the cardiac monitor? If the pacemaker is firing, what will you see? What wave will you see? No, because again, if the SA node fires, it will form a P wave. It's not the pacemaker firing now. I mean, it's not the SA node firing now. It's not a pacemaker. So what will you see? Okay, so you'll see a pacemaker spike. So instead of a P wave, you'll see something like this.
They're gonna look a QRS, right? The chart.
No, it's well, depends on which lead you're looking at. So if it's lead 2, this is lead 2, this is what you'll see. Okay, although this patient has a pacemaker, so atrial and ventricular pacing spikes. So this one is both atrial and ventricular spikes. So you have a atrial spike, and then you also have a ventricular spike. Okay, so this is dual. Sometimes it's like that, or sometimes the patient will just have an atrial pace like this one. So this is only atrial. This is lead, most likely this is lead AVF.
No.
Yeah, this would be AVF, I think. No, AVL, sorry. It's AVL. So this is what you'll see. It's upside down because it's AVL. No, it's the left leg. But if this is in lead 2, this will be up. Okay, so this is what you'll see. So instead of a P wave, you'll see a pacemaker spike. Okay, so this one here in this example here, you have two. You have an atrial spike and a ventricular spike. Okay, so meaning the patient has is both atrial and ventricular paced. This patient down here, only the atrium is paced. Only the atria are paced. Ventricles are not. All right. Complications are the following. Chart 22-7. So right after insertion, there'll be local infection, a pneumothorax. This is related to the insertion procedure. No, sometimes the doctor may have sliced too deep and sliced into the pleura, causing a pneumothorax or bleeding, hematoma, all the way here. Now, besides that, here are now your problems. This usually caused by either the battery. These batteries can last 10 years or longer. So every 6 months though, anyone who has a pacemaker, it has to be checked. So that's twice a year. And then as needed, every time the patient has symptoms, then the pacemaker will also be interrogated. But these are the common problems. I won't test. That's okay. We have too many questions now. So I'll skip table 22-2. I do have questions on your teaching. Okay, so it's not in a table though. It's in a paragraph, 2 big paragraphs. So from here to here. All right. So will this be a select all that apply?
Yes.
Yes. Okay, so what do you teach the patient? The easy part here is when we go to ICDs, the treatment, the teaching is the same. Okay. ICDs pacemaker have similar teachings. So you don't have to study separate one for ICDs. Okay, that's a good thing. So what do we teach the patient? Avoid strong electromagnetic fields. So what are equipments that have strong electrical magnetic fields? Okay. Okay, anything that has large magnets, MRIs, welding equipment, large stereo speakers, sorry. Stereo speakers have large magnets. Okay. What
What
else?
is this? No, like,
Teaching. What do you teach the patient, right? So you don't want any large magnets, okay? Anything, again, welding equipment, those have magnets, okay? Anti-theft devices in the stores, okay? But you can walk past them, just don't hug them, okay? It's okay, you can walk past them. Definitely in TSA, you're in that big magnet wherein you do this and then that thing goes around. That's a big magnet. So no, you're gonna have to ask the TSA officer to manually violate you, okay? So show them your pacemaker ID. Hey, I have a pacemaker, and then you'll be manually violated. Yes? The what? Jet engines, yeah, those, let's say big jet engines, those have big magnets. Or let's say in electric cars though, they did say it doesn't interfere in the testing. So a Tesla or any other electric car, they're fine. You can drive an electric car with a pacemaker. Okay, they said it doesn't interfere with that. It's safe. Well, that's what they say. Okay, so I'm guessing, you know, they're approved, so should be okay. Contrary to what you may see, especially in older city hospitals, they still have signs that are 50, 60 years old, because these hospital buildings are old. They still have signs there that microwave in use, avoid if you have pacemakers. Those are old, okay? That's no longer true. Because I don't think we still have 50, 60-year-old microwaves, do we? Well, probably in some mom and pop, godforsaken parts of I-80, maybe. Yes, there's probably gas stations there that still have 50, 60-year-old microwave ovens. But modern microwave ovens are fine. So here clearly says pacemaker technology allows patients to safely use most household electronic appliances. You can use microwave ovens, you can use electrical tools. So power tools, they're fine. Okay, let's say, you know, power drills, they're okay. Here, so gas-powered engines, these are big. Okay, so definitely no. Here, so if you have earpiece of a phone, large stereo speakers, only for a few seconds. Cell phones, it should be 6 to 12 inches away.
The opposite.
Well, as long as it's six inches away. So where is the pacemaker?
Here.
Usually on the left. It's usually on the left. So where will you hold the phone? On your right. Can I use a selfie stick?
No, because you can't
Yes.
read.
You can.
Yeah.
And that's way low. Inches.
Because I be seeing people lift it up like that.
Yeah. Again, I won't read the whole thing for you. Please read on your own. So here about TSA, go airport. It will trigger store and library anti-theft devices. However, these do not interfere with pacemaker function, except again that large one in the
When
TSA.
you're getting an MRI, you get a CT scan.
Okay, for MRI, depending on the type of pacemaker you have, there are MRI safe pacemakers now. This is the 21st century. We do have MRI safe pacemakers, but you have to ask what type you have. So you have an older one, then definitely no MRIs. Pacemaker, so I said how many times is it checked?
Twice a year.
Every 6 months. ICDs. So who gets an ICD? What is an ICD? Implantable cardioverter defibrillator. So what is it? It's a miniature
It's a mini one.
defibrillator. So you grab this one, turn it into a tiny bitty device. There you go. That's a defibrillator cardioverter. Because it's small, will it deliver 360 joules? No.
No.
It can deliver smaller, let's say 50. Okay. So it's smaller. So it's a computer. So it has the ability to, what are the two rhythms again that are shockable? VFib and pulseless VTAC. So if the patient throws those, then the ICD will fire. As simple as that. So who gets it?
Patients who have second heart block, type 2, and third heart block. No?
This is not a pacemaker. This is a defibrillator. Okay, so here,
SBT.
can you read it, please?
Patients at high risk of VT or ventricular fibrillation who would benefit from the IC and are those who have survived sudden cardiac death, which usually is caused by ventricular fibrillation or have experienced spontaneous symptomatic VT.
Continue.
Oh,
Not
They could
due.
be secondary to VT and not due to a reversible cause called a secondary prevention intervention.
So that's who gets an ICD. Okay, remember there is a transvenous, right, pacemaker? Okay, so this ICD also has a bridge. Life vest is an external ICD. So the patient wears this. It's a vest, so you put this over your skin and you put your clothes over it. So, because otherwise, if you put this over your clothes, will it have any contact with the, no. So you put this on the skin and then you put your clothes over it, okay? So it's a vest, and then these electrodes are strategically placed. There has a battery in it. This one will be put in a sling because it's heavy. It's not gonna hold on the vest because otherwise it will drag the vest down. So you recharge the battery every every few, whenever it dies or is low. So this brand is Zoll Life Vest. I haven't seen any. Well, I've only seen them in, yeah, I've never seen a different brand, Zoll. So let's say the patient has, again, same thing as the transvenous. Let's say the patient who had the pacemaker earlier. Tenine. Let's say Tenine also has a need for ICD. She can't get it yet, right? Because she still has an infection. So she has to wait. So meanwhile, she'll wear this. So she'll go home with this. And then once her infection is clear, then she'll get her ICD implanted.
kitchen.
Okay, and here's your, you can do this for both pacemaker and ICD.
The
Okay, so
education.
this chart here, 22-9, it'll be the same. So tell the patient what to do, what symptoms to report. So here for local infection, for instance. Okay, avoid heavy lifting. So I won't read them for you, responsible for that. So this is what I meant by it's similar to pacemaker. Here's something for the sexual partner. Okay, so because can sexual activity trigger VTAC or VFib?
Yes.
Yes, okay. So to no, not to scare the partner, because the partner may say, oh, I'm not having sex with you, I don't want to get electrocuted. It's not really that big of a shock. Okay, so assure them they're tiny shocks, it won't cause electrocution. Because it can fire, it can cause the device to fire. Questions?
But if they agree this will be cardiac,